So now at this point, we've developed a heart that has one atrium and one ventricle. And we need to convert that into a heart that has two atria and two ventricles. So we're going to accomplish that through a process called septation, the development of septa, of walls. There's going to be atrial septation and there will be ventricular septation. They are separate processes. They occur in an overlapping temporal fashion. The atrial septation begins first, and before it's finished, ventricular septation has begun. So they overlap with the atrial septation leading the ventricular septation. So atrial septation occurs from about the latter part of the 4th week through the early part of the 6th week, and ventricular septation occurs from about the early part of the 5th week through the early part of the 7th week. So they overlap. So let's start off with atrial septation and see how that happens. It's very helpful to us if before we take a look at how it happens, if we take a look at what the end result is going to be so that we can relate the embryonic events to the adult structure. So on this slide, we're looking into the right atrium. We're in front of the heart. We've made a cut in the anterior wall of the right atrium, folded that flap back here. We're looking into the right atrium. There's the tricuspid valve leading over to the right ventricle. There's the IVC, the SVC is coming in there. As we're looking at this back wall of the right atrium, what we are indeed looking at is the atrial septum. The back wall of the right atrium is the septum. Because remember, the left atrium is in the back of the heart. It's behind the screen. So this wall is separating the right atrium from the left atrium. So it's the atrial septum. And when we look at the atrial septum, we see a very distinctive landmark on it, right there, called the fossa ovalis. Fossa meaning it's a depression, an oval-shaped depression. The reason that portion of the septum looks like a fossa, like a depression, is because that part of the septum is thinner than the rest of the septum. This part is thinner than all the rest of the septum. And the reason for that has to do with how the septum forms. It actually forms from two septa, side by side. So much of the septum is in fact two septa thick, two septa superimposed one upon another. So that's what all of this is. But this part of the septum is only one septum thick. And since it's only one septum thick, it's thinner than the part of the septum that's two septa thick. And so we end up with this fossa ovalis, which is showing us which part of the atrial septum is made up of only one septum. Now those two septa, as we'll see shortly, have the names septum primum and septum secundum, meaning the first septum and the second septum. And what we're seeing here in the fossa ovalis is the part of the septum that's made up of only the septum primum. The rest of the septum is made up of the septum secundum overlying the septum primum. So it's two septa thick. The other thing I want to point out on this picture is this rather sharp upper border, very distinct upper border of the fossa ovalis, which is given a name limbus, limbus of the fossa ovalis. Limbus means lip or edge. So that's the edge or the lip of the fossa ovalis. And that's going to have a specific relationship to some embryonic structure that we'll talk about in a few minutes. And the last point I want to make is we're going to see in a few moments that during development there is an opening in the atrial septum called the foramen ovale, which is a very important structure in the fetus and in the embryo. The adult position of where the foramen ovale was is right under that edge, right under that limbus. If I could stick my arrow into the screen right there, I would be passing my arrow into what used to be the foramen ovale. That's where it was. In other words, the upper border of the fossa ovalis. Now, in the notes, there's a series of diagrams. We can see a couple of them here and then the remainder of them here. And these diagrams are illustrating the formation, the embryonic formation of the atrial septum. And while they, in fact, do that, It's a bit too complicated to try to understand it, I think, just from looking at these diagrams. So what we're going to do is look at a few very simplified diagrams to see how the atrial septum forms, and then once we understand it, we'll come back and look at these diagrams, and it'll be easier for us to understand these diagrams at that point. This diagram is a simplified schematic of the embryonic atrium. This region here would represent the atrium. This, continuing down off the screen, would be the ventricle. See that this portion has enlarged, this portion is enlarged. At the junction between the two, it has not enlarged as much, so we have this narrowed region called the atrioventricular canal. On this diagram, this would represent the right side, and this would represent the left side. So what we're going to want to do is take this common atrium and divide it into two atria by building a septum down the middle. But recognize that there's no point in dividing the atrium into two atria if we don't also divide the atrioventricular canal into two canals. Because if we don't do that, we'll have two atria draining into a common outlet, so the blood would mix together. So we need to divide the canal into two canals as well. So let's take care of that first. So let's start off by dividing that atrioventricular canal into two. So there'll be an ingrowth from the wall of the heart tube into the canal, and that ingrowth is going to be called the endocardial cushion. Now, it's noteworthy that the cells that become the endocardial cushion, although I'm saying they come from the wall of the heart tube, they were not originally part of the heart tube. They migrated to the heart tube. They're actually neural crest cells that migrate to the heart tube. Neural crest, as you recall, is one of the derivatives of the upper layer of the three-layered embryo. And neural crests will develop into many different things, including nerve cells, which we've already discussed, but also many other things. And one of the things that characterizes neural crest cells is that they migrate all over the embryo to become many different things. And so we're going to see different structures in different parts of the body that are all neural crest structures. They don't seem to have much else in common. But one of the things we need to be cognizant of is that, as a general principle, when there are cells that are supposed to migrate during development, sometimes they don't migrate properly, sometimes they don't end up where they're supposed to end up, and that will result in some kind of developmental defect. And in the case of defects of neural crest migration, we can anticipate that when we see one defect that can be identified as a neural crest migration defect, we should anticipate that there may be other defects that seem unrelated, but their common denominator is that they are neural crest-derived structures. So one neural crest migration defect will predict other neural crest migration defects. So the endocardial cushion is a neural crest structure, and we will talk about some defects relating to the endocardial cushion in just a few minutes. But with that endocardial cushion in place, we now have a right and a left atrioventricular canal. So now we can proceed to develop the atrial septum. Now, before we go ahead and do that, it's useful for us to think through what it is we want to accomplish and what are the functional requirements of this septum. And fundamentally, there are two major functional requirements that we have to satisfy. The first is that while we want to divide the atrium into two, we want to do it in such a way so that throughout development, and in fact throughout all of prenatal life, there is a communication between the right atrium and the left atrium. We can never completely separate those atria during development, during prenatal life. The reason for that is that the source of oxygen for this embryo and then fetus is, of course, the placenta. And the blood from the placenta is coming to the embryo through the umbilical vein, and the umbilical vein drains into the IVC, and then the IVC drains into the right atrium. So that means that the fetus's or embryo's oxygenated blood supply is coming into the right side of the heart. But of course, that oxygenated blood has to leave the left side of the heart in order for it to get into the aorta to distribute to the fetus and embryo. So therefore, there must be a pathway to allow this oxygenated blood to get from the right side of the heart to the left side of the heart. And that pathway is going to be through an opening in the atrium. Now, of course, postnatally, that problem goes away because postnatally, the source of oxygenated blood is the lungs, and the blood from the lungs comes to the heart through the pulmonary veins, which drain to the left atrium. So the oxygenated blood is coming into the left side of the heart and leaves the left side of the heart, so we don't have the issue of having to get blood across from one side to the other. But throughout prenatal life, we do have that issue. Therefore, we have to build the septum in such a way that there will always be a communication. The second requirement is that we also need to build it in such a way so that right after the baby is born, we can close off that separation immediately. And therefore, that means we have to be able to close the communication using the material that's already there. We can't build a new septum after the baby is born. We have to use the septum that's there. So it has to be built in such a way so that it remains the two atria remain in communication throughout prenatal life, but that communication can be immediately closed at birth. So let's see how we accomplish that. I said previously that the atrial septum comes from two septa, with the first one called septum primum. So let's start with that. Septum primum grows down into the atrium from the upper wall of the atrium, growing down little by little into the atrium. Now it's going to keep growing, but I've stopped it at this point so we can talk about it a little bit. So that's called septum primum. So at this stage, we can say that septum primum is partially separating the atria, but certainly not completely. We still have this great big communication here. And that communication is given the name foramen primum, first opening, foramen primum. Notice that the foramen primum is not a hole in septum primum. It's a region of the atrium where septum primum has not yet grown. Or to put it another way, foramen primum is the space between septum primum and the endocardial cushion. So that means that as septum primum continues to grow longer and longer and longer, by definition, that means foramen primum is getting smaller and smaller and smaller. So let's see that. Let septum primum continue to grow. Down it goes. Foramen primum is getting smaller. It's now much smaller. And if we allow that process to continue, septum primum will meet the endocardial cushion. They'll fuse together. We'll call that closure of the foramen primum. But if that were to occur at this stage of the game, that would mean we will have completely separated the atria, which means the embryo would die, because we can't completely separate the atria. So what's going to happen is the following. In fact, septum primum will continue growing down, and it will meet with the endocardial cushion, and they will fuse. But before that happens, another opening will form. It'll form within septum primum, and that opening will form by a process known as apoptosis, programmed cell death, where that will result in perforations of the septum in this region. The perforations will coalesce, something like that, and that will result in an opening, and that opening is called foramen secundum. So foramen secundum is a hole in septum primum. So now that foramen secundum is there, now it's okay for foramen primum to close. And so that's what will happen. And it will happen actually by septum primum growing down, but also the endocardial cushion growing up. They will grow toward each other. So septum primum will grow down more. The endocardial cushion will grow up. They'll come together. They'll fuse. Once they fuse, we call that closure of foramen primum. But now that's okay because we already have this opening, so we've maintained a continuous pathway from right to left. While this process is occurring, a second process is going on simultaneously, and that is the formation of septum secundum, the second septum. Now, septum secundum is also going to grow down from the upper wall of the atrium. It's going to be on the right side. Remember, this is the right atrium. It'll be on the right side of septum primum. And importantly, septum secundum is going to be a much thicker septum than septum primum. Septum primum is thin, and as a result of being thin, it's flexible. Septum secundum is thick and it's rigid, and that's going to be an important difference. So here comes septum secundum growing down. It's thicker. It's on the right side of septum primum, and it grows down for a while. It grows past foramen secundum, keeps going for a little bit further, and then it stops. And that's as far as it goes. We're actually finished building the atrial septum at this point. Before we look at how it works, let's just relate what we have to the adult structure that we looked at a little while ago. So if you recall, we looked at the atrial septum. We said that there was a fossa ovalis, and we said that the fossa ovalis is the part of the septum made up of only septum primum. Well, here's the part of the septum made up of septum primum, so that is the fossa ovalis. We said that the upper border of the fossa ovalis was given the name limbus of the fossa ovalis, and so here we see that that upper border would be the edge of septum secundum. So that free edge of septum secundum is in fact the limbus of the fossa ovalis. So that helps us understand why it looks the way it looks in the adult. But we still are faced now with the question of how does this work? Because at first appearance, it seems that after making a big fuss over the fact that we have to maintain this communication, septum secundum seems to have covered over that communication. So that doesn't seem very good. But in fact, it works just fine. So we have to consider the blood flow through the heart and some hemodynamics related to that blood flow. Flowing into the right atrium is all of the venous return from the embryo or fetus, as well as all of the venous return from the placenta that came in through the umbilical vein. So there's a very large volume of blood flowing into the right atrium. Coming into the left atrium, the only veins that come into the left atrium are the pulmonary veins. That means the only place blood could be coming from is the lungs. And we know that prenatally, very little blood flow goes to the lungs because the lungs haven't expanded. There's a very high vascular resistance in the pulmonary circuit. So very little blood flow goes out to the lungs, therefore very little blood comes back from the lungs, so very little blood comes into the left atrium. So we're saying we have a lot of blood coming into the right side, very little blood coming into the left side, which means we end up with a pressure on the right side that's high and a pressure on the left side that's low, meaning that we have a pressure gradient from right to left. That pressure gradient is pushing against the septum. Recall we said that septum primum is thin and it's flexible, so that pressure gradient pushes against the flexible septum primum and pushes it to the left, separating it from the septum secundum, creating this pathway, and it is through that pathway that blood can flow. That pathway that we have created now is called the foramen ovale. So we can say that the foramen ovale begins in the fossa ovalis, continues between the two septa, and ends at the foramen secundum. It's really a three-dimensional tunnel as opposed to a two-dimensional hole. And so throughout all of prenatal life, that's how the embryo and then fetus lives, with blood shunting from right to left through the foramen ovale because of the right to left pressure gradient. So then we said that at birth we need to be able to separate the atria immediately. So how does that happen? Well, after birth there are two significant changes in the blood flow coming into the heart. One important change is that the umbilical vein, which was carrying all of that placental blood to the right side of the heart, closes down. So with the closure of the umbilical vein, we don't have the placental return coming into the right side, which is a dramatic decrease in volume. So the volume coming into the right side of the heart dramatically drops. The other important change is that at birth the lungs expand, the vascular resistance in the pulmonary circuit drops. As a result of that, the blood flow to the lungs increases dramatically, which means the blood flow coming back from the lungs increases dramatically, which means the blood flow into the left atrium increases. So we have the blood flow to the right side decreasing, the blood flow to the left side increasing, and that results now in a pressure that is higher on the left than it is on the right. So that means we'll still have a pressure gradient, but now the pressure gradient will be left to right. And that left to right pressure gradient will again push the flexible septum primum, this time pushing it toward the right side, but it will push it up against the rigid septum secundum. Because it's rigid, it won't bend out of the way. And so that pressure gradient has pressed the two septa together and closed the pathway. So even though the fossa ovalis is still there and the foramen secundum is still there, we can't get from there to there because the two septa are pressed together. And it's that pressure gradient that keeps them together. Now note that I did not say that they fuse together. Although it is true that in most people they do eventually fuse, at the time of birth they don't fuse, they're simply pressed together. And then over the course of time, in most people they eventually fuse, but in some people they never fuse, in many other people they partially fuse. But it doesn't matter whether they fuse or not as long as there is a left to right pressure gradient. If as a result of abnormalities, pulmonary hypertension, pulmonary embolus, or something of that sort, you were to get a right to left pressure gradient, then if those didn't fuse, you can get a reopening of the foramen ovale. But under normal physiology, foramen ovale remains closed regardless of whether it's fused because the left to right pressure gradient keeps it closed. So that's the normal development of the atrial septum. And we can now go back and look at the diagrams that are in the notes and I think understand them a bit more easily. So what we see on this diagram, firstly you see the representation that the pressure is higher on the right than it is on the left. So we have a right to left gradient and that blood is flowing through the foramen primum, which is this gap between septum primum and the endocardial cushion. On the next slide, we see that the septum primum and the endocardial cushion have fused together, so there no longer is a septum primum, but by the time that happened, foramen secundum has opened. And so we still have a right to left flow, but now the flow is through foramen secundum. Meanwhile, we see that septum secundum has begun to grow down on the right side of the septum, and it hasn't yet gone past the foramen secundum, but if we go a little further, we see that it now has. It's overlapping foramen secundum, and that is now the normal septum, with blood being able to get from the right side to the left side because the right to left gradient has pushed the septa apart, and that pathway that this line represents is the foramen ovale, going from the fossa ovalis here to the foramen secundum over here. And then the last slide shows that after birth, when the pressure gradient reverses, it's now higher on the left than it is on the right. The blood pushes against the septum, closing foramen ovale, and although the blood is trying to push in that direction, it can't get through because those two septa are pressed together, and that's what we call closure of foramen ovale. So now things can go wrong in this septal development, and when they go wrong, they can lead to an atrial septal defect. And there are two major categories of atrial septal defect. Let's look at the first. We said that normally the septum primum grows down, fuses with the endocardial cushion, thereby closing off foramen primum. Well, sometimes that doesn't happen. Sometimes foramen primum does not reach the endocardial cushion, and foramen primum does not close. And so that means we're going to have a persistence of an opening here, a persistence of the foramen primum, and we're going to call that a primum type atrial septal defect, primum type ASD. And because postnatally the pressure gradient is left to right, that means blood flow, the shunting of blood will be from left to right. Now, when you have a left to right shunt, that means you're taking oxygenated blood from the left side of the heart and shunting it to the right side to send it back to the lungs. So you're taking oxygenated blood and sending it into the pulmonary circuit. That is not a cyanotic condition. Cyanosis results when you take deoxygenated blood from the right side of the heart and shunt it over to the left side, sending deoxygenated blood into the systemic circulation. So right to left shunts would be cyanotic, but left to right shunts are not cyanotic. So this primum type ASD is called a acyanotic or a non-cyanotic defect. Of course, that would also be true, although we haven't talked about it yet, if we were talking about a ventricular septal defect. Similarly, because the pressure is higher on the left than it is on the right, you'll have a left to right shunt. So that also is non-cyanotic. So those two defects, ventricular septal defect and atrial septal defect, which are by far the most common of the heart defects, are both non-cyanotic defects. However, recognize that even though it's not cyanotic, it's also not benign. The shunting of blood to the right side can eventually lead to an overload of the pulmonary circuit. And that overload of the pulmonary circuit can result in a change in the pulmonary vasculature, which will result in pulmonary hypertension, an increase of pressure in the pulmonary circuit. If that pressure in the pulmonary circuit gets high enough so that it eventually is now higher than the pressure in the systemic circuit, in other words, if the right-sided pressure rises so high that it's higher than the left-sided pressure, that means you'll get a reversal of the pressure gradient, and that very same defect, which we were characterizing as a left-to-right shunt, will now become a right-to-left shunt. And once that happens, it's now a cyanotic defect. So you've converted a non-cyanotic defect to a cyanotic defect, not by changing the defect, but by changing the direction of flow through the defect secondary to pulmonary hypertension. And that occurrence is what is known as Eisenmenger complex, where a defect that was not cyanotic initially, eventually later in life becomes cyanotic. So that's one kind of defect. Now, we know that this failure of the septum of the foramen primum to close, we said, is a result of septum primum and the endocardial cushion not meeting. Recall that we said that when they normally meet, it's because septum primum grows down and the endocardial cushion grows up. Well, we now know that when this defect occurs, it's typically because of a defect in the endocardial cushion, that it's a failure of the endocardial cushion to grow up rather than a failure of the septum primum to grow down. And that failure of the endocardial cushion to grow up is probably a result of an inadequacy of neural crest cells in the endocardial cushion, which is secondary to a defect in the migration of neural crests to the heart tube. So a primum type ASD is a neural crest migration defect, resulting in a defect in the endocardial cushion, which leads to this primum type defect. Now, associated with that are valvular defects of the tricuspid and mitral valve, because you can see where the endocardial cushion is. There's the right and the left atrioventricular canals. That's where the tricuspid and mitral valves would normally exist. And in fact, those valves are contributed to by the endocardial cushion. So the same endocardial cushion that resulted in a primum type ASD, the same defect of the endocardial cushion that resulted in a primum type ASD, may also be resulting in valvular defects because of the contribution of the endocardial cushion to those valves. So it's not a surprise that we know that there's a statistical correlation that a child who has a primum type ASD is at higher than average risk of having valvular defects associated with that. Now, the other kind of defect, we've fixed the first defect now, the other kind of defect relates to the formation of foramen secundum. Remember, we said that foramen secundum is created as a result of a process known as apoptosis, a programmed cell death of the septum primum in this region. Well, if there is an excessive amount of apoptosis, if too much of the septum primum perforates, we can end up with a foramen secundum that's too big, like this. And as a result of that foramen being so big, septum secundum no longer is overlapping it. So that means that when we have a reversal of the pressure gradient at birth, that would normally cause septum primum to push to the right and normally push up against septum secundum and thereby close foramen ovale. Because of the failure of these to overlap, because the foramen is so big, we cannot have closure of the foramen ovale. And we call that a secundum type ASD. We can also call that a persistent foramen ovale. And that persistent foramen ovale or secundum type defect will also result in a left to right shunt, which means it also will be acyanotic. Because that defect has nothing to do with the endocardial cushion, it has nothing to do with neural crest migration. So secundum type ASD is not a neural crest migration defect and therefore is not associated with other neural crest migration defects. It is a defect relating to an excessive amount of apoptosis of the septum primum. So if we were to look at a photograph of an atrial septum that had a defect in it, had a hole in it, we would actually be able to tell which kind of an atrial septal defect it is based on its position. Because if we go back to the previous slide, we know that a primum type defect would be here near the endocardial cushion, and a secundum type defect would be here near the top of the fossa ovalis. So when we look at the adult, that means a secundum type defect would be in this region near the top of the fossa ovalis, and a primum type defect would be here because the endocardial cushion was right next to where the valve is. So primum type defects are in this region near the tricuspid valve. Secundum type defects are in this region near the top of the fossa ovalis. If you see where the defect is, you know which kind it is. If you know which kind it is, you know which developmental process resulted in that defect. A neural crest migration defect in the case of this one, and excessive apoptosis in the case of this one. Now let's turn our attention to how we separate the ventricle with the creation of a ventricular septum. So in this schematic diagram, this will represent the ventricle, and this would represent the outflow from the ventricle. In other words, the upper end of that heart tube, the truncus arteriosus. So that's the ventricle, that's the truncus arteriosus. And we're going to want to separate this into right and left. Now, just as we said before when we were talking about the atrial septation, there's not any point to separating the ventricle into two ventricles unless we also separate the outflow pathway into two pathways. So we're going to want to separate the truncus arteriosus into two, and we're going to want to separate the ventricle into two. We're again going to use two septa to accomplish this, but this time instead of the two septa being side by side, they're going to be end to end. So let's start with the first septum. There's going to develop a septum within the ventricle. Exactly how that develops is not something we'll take time to discuss. Suffice it to say that this septum, which we're going to call the embryonic ventricular septum, this septum is derived from the ventricular wall itself. It develops from the ventricular wall, which means it's made of the same material as the ventricular wall, which is to say it's made of cardiac muscle. So the embryonic ventricular septum is composed of cardiac muscle. Notice that that septum only partially divides the ventricle. It's not a complete septum. We still have this large communication. So let's leave that there and we'll come back to it. And now turn our attention to the truncus arteriosus. We said we need to divide the truncus arteriosus into two, and we're going to do that by having a septum grow right into the center of the truncus arteriosus, like that. Okay, there'll be a septum right down the middle of the truncus arteriosus. And the fact that it's right down the middle is important, because that means it divides the truncus arteriosus into two equal halves. So we're going to end up with two blood vessels of the same diameter. once that's happened, we'll name one blood vessel the aorta, the one coming out of the left side, and we'll name the other one the pulmonary trunk. And so this septum that transforms the truncus arteriosus into an aorta and a pulmonary trunk is called the aorticopulmonary septum. Aorticopulmonary septum meaning it creates the aorta and pulmonary trunk out of a truncus arteriosus. And as I said, because it's right in the center, the aorta and the pulmonary trunk will be of equal diameter, which is a good thing because the output from the left and right ventricles are normally equal. So we want to have equal sized vessels for that output to flow into. Now, this aorticopulmonary septum does not end when we get to the bottom of the truncus arteriosus. It actually continues on going into the ventricle. And because it is right in the center of the truncus, and because the embryonic ventricular septum is right in the center, those two septa end up meeting end to end and fusing, thereby completing the ventricular septum. So part of the ventricular septum in the adult comes from the embryonic ventricular septum, and part of the ventricular septum comes from the aorticopulmonary septum. When we look at the adult septum in the ventricle, we see that there are indeed two recognizable parts. One is called the muscular interventricular septum, which is made of cardiac muscle. So that's the embryonic ventricular septum, which we said is made of cardiac muscle. And the other is called the membranous interventricular septum because there is no muscle in it, and it's the downward continuation of this aorticopulmonary septum. Now, I will tell you that this aorticopulmonary septum is frequently called the spiral septum. That's an alternative name that we frequently use for it. And it's called the spiral septum because it in fact normally develops in the shape of a spiral, a 180-degree spiral. Now, on this diagram, we're representing it as if it was straight because the fact that it spirals is not important for this portion of our discussion. And so we'll keep it simple and just make believe it's straight. But in fact, it does spiral, and we'll come back and deal with that a little bit later when the fact that it spirals becomes relevant to what we're discussing. So that's the completion of the separation of the right side and the left side, and we now have the right ventricle flowing into the pulmonary trunk and the left ventricle flowing into the aorta. So that's the normal development. There are some abnormalities in this development that are related to abnormalities of the aorticopulmonary septum. Now, before we talk about those abnormalities, let me point out to you that this aorticopulmonary septum develops in the truncus as an ingrowth from the walls of the truncus arteriosus. Cells from the wall of the truncus grow in. They grow in a fashion that creates a spiral septum, but they're growing in from the wall. But again, these are not cells that were originally part of the wall of the heart tube. They are cells that migrated to the heart tube. They are neural crest cells that migrated to the wall of the heart tube and then went on to form the aorticopulmonary septum. So the aorticopulmonary septum is a neural crest-derived structure. And so again, we should think about neural crest migration defects, and that among the defects seen in these individuals may be defects of the aorticopulmonary septum. Now, defects of the aorticopulmonary septum typically result in cyanotic defects. The defects we've talked about up until now, atrial septal defects and simple ventricular septal defects, which are the most common defects, we said were not cyanotic. In fact, the third most common defect that we haven't yet talked about, patent ductus arteriosus, is also not cyanotic. But now we need to talk about some of the cyanotic defects. And we'll start off by using as a model for these defects the most common of the cyanotic defects, which is called Tetralogy of Fallot. So let's talk about Tetralogy of Fallot and see how that develops. Now, the word tetralogy, tetra meaning four, suggests that there are four components of this defect. And those four components are pulmonary stenosis, overriding aorta, ventricular septal defect, and right ventricular hypertrophy. That raises the obvious question of why do those four defects coexist with a high enough frequency that it's the most common cyanotic defect. That seems strange, that they should coexist like that. But it turns out the reason they coexist is that it's really not four defects. It's really one defect that gives the appearance of four defects. And the defect in tetralogy FLO is a defect in the positioning of the aorticopulmonary septum. We said that normally the aorticopulmonary septum forms right in the midline, and we talked about how important that was because it results in two equal size outflow vessels. Well, in tetralogy FLO, the aorticopulmonary septum forms displaced toward the right side, toward the pulmonary side, like that. Sometimes it's referred to as dextropositioning of the aorticopulmonary septum, dextro meaning to the right. As a result of that misplacement of the septum, instead of having two equal size outflow vessels, we now have two unequal size outflow vessels. The one that's too small is the pulmonary trunk. The one that's too big is the aorta. So this unusually small pulmonary trunk is given the name pulmonary stenosis. This overly large aorta is given the name overriding aorta. Overriding because it's so big that it's in fact straddling both ventricles instead of just the left ventricle. So we see that pulmonary stenosis and overriding aorta are fundamentally the opposite sides of the same coin. It simply means that the septum was displaced to the right. Well, because the embryonic ventricular septum is in the middle, and now the aorticopulmonary septum is not in the middle, therefore they don't meet, and therefore they don't fuse, so we now have a ventricular septal defect. So that's the third element of tetralogy. The fourth element we said was right ventricular hypertrophy, and that's not really a defect. That's a result of the defect. It's a physiological result of the defect because this right ventricular wall is working very hard to pump blood through the stenotic outflow pathway. It hypertrophies. So the right ventricular hypertrophy is a result of the defect as opposed to being a part of the defect. But now with that having developed that way, we now see that oxygenated blood from the left ventricle can certainly flow to the aorta. Deoxygenated blood from the right ventricle, some of it will exit the right ventricle through the stenotic pulmonary outflow, but a whole lot of it will get shunted following the pressure gradient. Because of this stenotic pulmonary stenosis, the pressure is higher on the right. Because of the overriding aorta, it's very simple for blood to flow that way. So we have some of the deoxygenated blood from the right side shunting across the ventricular septal defect, right to left, into the overriding aorta, and thereby mixing with the oxygenated blood. So the blood that goes out to the systemic circulation is not purely oxygenated blood, but rather a mixture. So that forms the basis of the cyanosis. This arrow basically represents the cyanosis. So in this defect, we have a right to left shunt, and as we said previously, therefore that is a cyanotic defect. So that's tetralogy FLO. So let's take a look at what that tetralogy FLO looks like in the adult heart or in the postnatal heart. And what we see here now, there's the right ventricle, there's the left ventricle, there's that pulmonary trunk, which is quite narrow. So right there is the pulmonary stenosis. Here's that ascending aorta, which we see is straddling the left ventricle and the right ventricle. So we have this enlarged aortic outflow, an overriding aorta, and we have this stenotic pulmonary outflow, and we have this ventricular septal defect. And then, as we said before, you see that the thickness of the right ventricular wall is comparable to the thickness of the left ventricular wall, which is not normal. That's because we have this right ventricular hypertrophy because of the hard work it's doing trying to pump against this stenotic pulmonary outflow. So that's tetralogy FLO. Another defect of the aortical pulmonary septum is one in which the aortical pulmonary septum simply does not form. So since we said normally that the aortical pulmonary septum converts the truncus arteriosus into an ascending aorta and a pulmonary trunk, if we don't have an aortical pulmonary septum, we'll be left with a truncus arteriosus. And so we call that defect a persistent truncus arteriosus. A failure of the aortical pulmonary septum to form leaves us with a truncus arteriosus, which means that the deoxygenated blood from the right ventricle and the oxygenated blood from the left ventricle are both flowing into a common outflow pathway. And even though those pathways will separate a little further downstream, by the time they separate, the blood has already mixed. So the blood that is going out into the systemic circulation, again, is not just the oxygenated blood, but a mixture of oxygenated and deoxygenated. So that also is a cyanotic defect. Now, it's obvious when looking at this picture that if you don't have an aortical pulmonary septum, that means you're also going to have an incomplete ventricular septum, because, as we said before, the ventricular septum normally forms from the embryonic ventricular septum plus the aortical pulmonary septum. So without an aortical pulmonary septum, you'll also have a ventricular septal defect. So we can say that there's a 100% coincidence or coexistence that when there is a persistent truncus arteriosus, there will always be a ventricular septal defect accompanying it. And as I said, that will be a cyanotic defect. And so what we see here is the result of that. There is that interventricular septal defect that we said we would have, and here we see a common outflow, a truncus arteriosus. And although further downstream it does divide into aorta and pulmonary, by the time that has happened, the blood has mixed together. So it's cyanotic. We have cyanotic blood going out into the aorta, or partially deoxygenated blood going into the aorta and the pulmonary trunk. The next thing to discuss relates to the fact that we said that this aortical pulmonary septum normally forms in the shape of a spiral. So when we look at this picture, the artist has demonstrated that that septum, that aortical pulmonary septum, is in the shape of a spiral. So we can see that if we start here in the left ventricle and we go up and to the right and then back to the left, from the right ventricle we go up and to the left and then back to the right. So we see this spiral shape to the septum, and it has that shape because, as I said before, it develops by an ingrowth from the walls of the truncus arteriosus, and when we look at this picture, we can see that at this level, it's growing in from this side and this side. We go up a little higher, it's growing up from the front and the back. We go up a little higher, it's growing in from the sides again, but now the opposite sides. When we put all of those ingrowths together, we end up with a spiral-shaped septum, which means we end up with an adult structure that looks like this, with the aorta coming out of the left ventricle, going up and to the right, and then arching back to the left, and the pulmonary trunk coming from the right ventricle going up and to the left. And so that now explains why we have what seems like an unusual circumstance of having the ascending aorta on the right and the pulmonary trunk on the left. It's because the septum is in the shape of a spiral. But what if, when that aortical pulmonary septum forms, it does not form in the shape of a spiral? What if, in fact, it forms as a straight septum? So instead of the adult looking like this, what we would have is the ascending aorta, instead of, as we follow it back, having it slipping over toward the left, it would go straight back down into the right ventricle. And similarly, the pulmonary trunk would come straight down to the left ventricle. So instead of spiraling around one another, we'd have two parallel vessels, but that importantly means we have the right ventricle feeding the aorta and the left ventricle feeding the pulmonary trunk. In other words, the vessels are backwards. That's the aorta, that's the pulmonary trunk, and we call that transposition of the great arteries. Transposition of the great arteries. Now, realize that that means we have two parallel, non-overlapping or non-intersecting circulatory systems. We have one circulatory system that comes out of the right side of the heart, goes into the systemic circulation, and then comes back to the right side of the heart from the systemic circulation, only to go right back out to the systemic circulation again. So we have deoxygenated blood circulating between the body and the heart. And on the left side, we have oxygenated blood from the left ventricle going out to the pulmonary trunk, out to the lungs, coming back to the left side of the heart, right back to the left ventricle, going right back out to the lungs. So we have a closed circuit of oxygenated blood going back and forth between the heart and the lungs. It should be apparent that prenatally this would not be a problem, because prenatally oxygenated blood comes into the left side of the heart. So the fact that the oxygenated blood comes into the right side of the heart prenatally. So the fact that it's feeding into the aorta prenatally is not a problem. But postnatally, as soon as the placenta is no longer the source of oxygen, we would expect that this child could not live beyond birth. But in fact, transposition of the great arteries is a not uncommon cyanotic defect, meaning that the children do often live, albeit with cyanosis that presents at birth. And the reason that's true is that these children who are born alive with transposition always have other defects. They have other defects that allow for mixing of blood between the right and left side, whether they be septal defects or other defects. They have defects that's allowing some mixing, and it's that mixing that's allowing the child to stay alive. And then eventually, that transposition would have to be surgically repaired. And these days, that gets repaired really quite early after birth. So here we see the adult appearance of transposition, where we see the right ventricle feeding into the ascending aorta, and we see the left ventricle feeding into the pulmonary trunk.